I'll be talking in brief about anti-VEGFs in ROP. In ROP in general, so I do not have any financial interest with any companies. So India has the highest number of preterm births, right? These figures are from 2010, around 35 lakhs or 3.5 million children are born with who are preterm. Okay, so this number obviously is going to increase with better infrastructure, and up to 18,000 of these infants will go blind every year if proper ROP screening is not done. This is from the government website, the data. As we know that with better infrastructure, better training, and as we move towards a developed nation, the infant mortality rate also falls, right? So as our infant mortality rate is falling down, simultaneously the rise of ROP also is occurring. Okay. In simpler words, ROP is a vasoprotective disease which, if not treated or screened or identified, can lead to permanent blindness. This is actually a reversible blindness, or rather, I'll say this is a preventable blindness. These are just few examples of how different variants of ROP or aggressive ROP can present. Okay, we have this looping shunting with avascular islands. This is a case with ocular albinism, and you have the dilated tortuous vessels. This is around halves on ROP, similarly here as well. So in the above scenarios which we saw, which were extreme cases of ROP, or rather aggressive ROP, what is the treatment modalities common to the 4 scenarios? Any options? Any guesses? It's anti-VEGF therapy. Okay. So just a brief about anti-VEGFs, not spending too much time. Currently, anti-VEGFs that are used for management of ROP is Avastin or bevacizumab, ranibizumab, and aflibercept. This is what people have been using. Okay, and I'll be presenting some data on the comparison of these 3 drugs. When you look at indications for injections, it can be aggressive ROP, any disease with plush disease, okay, any eye with plush disease, zone 1, stage 3 also with plus can be given injection, neovascularization of the iris, sick babies, salvage therapy after failure of laser, and subsequently before any surgical intervention, especially for a vascular condition, stage 4, stage 5 is rarely, but stage 4 ROP. The technique that we use is called as a SAFER protocol. SAFER is an acronym for short needle, use of antiseptic or antibiotic, that is betadine, prior to injection, environmental exposure. I'm skipping the F here because extra attention detail is very important, and it should have been come before, like assess for conjunctivitis, assess for any NLDO block, like nasal duct obstruction. That's very common for children, and they can have discharge as well. And follow-up. Effective follow-up is the key in the management of treatment of ROP post anti-VEGF. And recheck, that is a proper follow-up protocol along with use of FA whenever indicated. So the next question, if we ask, what is the preferred dosage of anti-VEGF? Worldwide accepted dose is 1/2. Okay. Problem is, real world scenario, we do inject with the 1 ml syringe and with a 29 gauge needle. Some may receive 0.05, some may receive 0.04, some may receive 0.02, 0.3. We just can't measure it. So actually, AI is artificial intelligence is helping us here to understand the dosage for each child. I'm not covering that thing here, right? So lower doses are not as effective. It's already been studied. So when you compare various anti-VEGFs, bevacizumab takes the lead here. Least recurrence, increased duration of action. Earlier, maybe around 5 to 8 years ago, there were reports of neurodevelopmental delays and all, but these children are very small, so they may have as such without the injection as well. So there is no clear-cut evidence or proof for which we can say that this drug is the causative factor for the neurodevelopmental delay. Right, ranibizumab has the least amount of action, the duration, and the maximum recurrence. So this is just few examples of what I showed earlier. This is the child with ocular albinism. We have published this in BMJ case reports. Important point here is look at the choroidal vessels and look at the retinal vessels, right? This are all choroidal vessels. This is a retinal vessel. Red free will help you to identify these vessels in a better way. Similarly, this is again a zone 2 ROP, zone 2 posterior, and you can see a very good development in around 12 weeks time. In case of disease recurrence, what is the criteria for reinjection? Recurrence important to define. It's an anterior recurrence or a posterior recurrence, whether it is a staged recurrence, okay, or a plus disease recurrence. There's no need to hurry. At the same time, you go and inject. You can wait for 3 days, 5 days, wait for a week. Few of the recurrences can spontaneously resolve, right? You can always have an option when the recurrence happens, especially post bevacizumab. You have enough time. The retina is gone to zone 3 and all, so you can do a laser, offer a laser. Whereas with ranibizumab, the recurrence can be in zone 2 itself. You may need repeated injections. Okay, follow post anti-VEGF as per the protocol, weekly for a month, then 2 weekly. But this increases the burden for individuals, right? So what happened during COVID? We got a chance to study our patients, where we call them after a month, after 2 weeks, with based on experience. We realized that patients coming after a month also nothing is going to happen. But this is only with bevacizumab, no other drug, right? So this is what we are following in between, having a balance between weekly as well as compared to bi-weekly or once in 3 weeks, or a local follow-up as well. Short and sweet, we did a study about the efficacy of bevacizumab as monotherapy. So we were not happy with the laser performance, and that is the reason why we went ahead with bevacizumab. 298 eyes of 151 patients we included in the study. Gestational age of 31 weeks was the mean. Post-menstrual age at presentation was 36, and at the injection also was around 36. That means we did not spend too much time in delaying the injection. Meantime, for regression of ROP was around 42 weeks. So if you see, only in a week's time, the ROP had regressed post bevacizumab. Respiratory distress syndrome was the most common systemic risk factor here. Recurrence post bevacizumab was 16% compared to ranibizumab, it goes on to 50%. And low birth weight and extreme prematurity was in multifactor analysis were the most important factors. Along with the single dose of bevacizumab, we had 84% of children having regressed APROP. Conclusion, ROP regression rate after one intravitreal bevacizumab was 84%. Just few more slides, I know it's running out of time. Maybe the last slide. Anti-VEGF treatment is here to stay. Advantages, easy to use. Anyone can use it anywhere, in NICU, in the OPD, in the OR. Rapid response, lesser myopia, better visual fields, right? Caution, delayed vascularization, recurrence, and challenging follow-up. I have cancelled deliberately long-term effects unknown, because we know now long-term effects are not that common. Thank you so much.
What was the follow-up period for these babies?
In our study, I think it was, so this was little biased in a way, because we also have rehabilitation in the same campus, right? So if we, just 1 second please. No, it's okay, I don't need the time. So the mean follow-up was around 10 months, 9.19 months. But this includes the period of COVID as in between, where they could not follow up. And we have children who are operated or injected prior, or may require surgery later on, who are still following with a rehabilitation team, or they may develop CVI as well. So that follow-up also was taken into consideration.
Okay, and only after one injection?
This is just the data of monotherapy.
Monotherapy. Yes. Only single injection?
Single injection bevacizumab. We have 84% chance of regression of ROP. We had a recurrence where 4 babies required bilateral injections for treatment of recurrence. We have excluded ranibizumab data from this. We wanted to just look at our bevacizumab monotherapy outcome. We still have a second study going on here, where we are assessing the refractive errors at 4 years, 5 years, 6 years. That is what we are planning.
In one study, it was noted that hypermetropia is more commonly seen with anti-VEGF drugs, as it is seen that myopia is seen commonly with the lasers.
So, to be honest, it's not predictable. We can't predict which eye is going to develop. I have cases which have even -10, -12 post anti-VEGF.
Post anti-VEGF?
Yes, few cases, because genetics, environmental factors also play a role here.
That is true.
And plus the prematurity. The more preterm the baby, more higher chance.
Yeah, no, see, it is always said that myopia is because of the laser done.
True. If you compare just with the laser arm, definitely there is a significant amount of reduction in the myopia when the children grow up.
And what about hypermetropia?
I have to look into it. It's a good question. I'll look into it.
Because that is one thing I read that.
But at what age you are talking about?
See, it was a very short. It was not a long-term study.
Okay.
But yes,
because this eye is going to go into immetroposition process as well.
Yes, exactly. And another thing, yes, you rightly pointed out that neurodevelopment delays. We are not knowing whether it is because of the prematurity of the baby, but yes, that is one thing we need to take care, because.
So luckily, Vizag has a very good infrastructure in terms of Rainbow and a lot of other OmniRQ, like very good brands have come here, and even they manage 24 weekers, 25 weekers when they're in the hospital for 2 months, 3 months, 6 months as well. So then you can't just understand what is going wrong with the baby. And then after a few years, we realized okay, this baby has an HIE or rather hypoxic ischemic encephalopathy or a CVI component as well.
One last question. If you want to repeat the injection,
Yeah.
so I mean, what should be the minimum time span between the two injections?
So again, as I mentioned with bevacizumab, the recurrence is later on, even around 58 to 60 weeks. By the time it is grown till zone 3. So I give an option to the child, to the parents, that let us examine the general anesthesia, get a proper IOP and a refraction check, okay, and at the same time get it laser done. That way, if I see that if at all it's progressing, it's improving, we may not go ahead with laser. But if the patient is from, so we have patients from Jamshedpur, Uttar Pradesh, Kolkata coming here, we don't give a chance. We just laser them because a small amount of lasers are required.
I mean, re-injected the patient?
Re-injected for ranibizumab, yes. For razumab, yes, which are injected outside. We don't inject razumab and ranibizumab, as in like biosimilar and eccentrics. We don't inject in our institute for children.
But bevacizumab, you have not.
No, for this 4 cases, we have injected, re-injected.
Re-injected?
Yes.
At what age? That's what I'm saying.
Around
what should
50.
Be the minimum gap?
Yes, 58 to 60 weeks, so 36, around 20 weeks later.
20 weeks later. Okay.
5 months
After
to 6 months.
4 to 5 months.
So how frequently?
Anybody from where audience?
Sorry? Yeah. No, we are examining the child at every visit. Okay, so sometimes you can make out whether there's a recurrence or not. If at 4 months also there's a recurrence, we give an option of doing laser. Sometimes the parents do not understand the condition. We take a call for the parents, depending on what is best for the child. Post-injection, I'm not sure. I have to look at the literature to be honest.
We have never seen.
Sorry for that.
We have never seen raised IOP.
Yeah, that's what I'm saying. I have to look at the literature.
We have
Never seen. It's quite
the
safe.
raised IOP after injection, but
Yeah.
transient is there clouding
Temporary
of the
it happens initially, just with the simple massage, it goes away.
Yeah.
Because the physiology takes care of it. But what you're asking, I'll give an anecdote for stage 4 ROP and stage 5 ROP, lens sparing and even lens involving vitrectomy with PPL. There is a chance of around 50% of those children going into ROP. So for our children who undergo surgery, we do start as a prophylactic AGM, and then we follow. When the child is big enough, then we can assess whether you need to reduce the AGM or stop it and all.
So what is your threshold of giving re-injection? Like you prefer re-injection or you want to do laser at this stage? Because almost
now we get a lot of referrals being a tertiary center. If there's a recurrence post ranibizumab, and if we see that it's only zone 2, I am going to re-inject. I'm not going to do laser because no point burning so much of retina when we have good evidence that it is going to improve.
So you think it improves? The ROP
Definitely.
regresses?
Yes.
So you don't need to do laser?
No.
In the follow-ups?
No.
And as you mentioned, at 60 weeks you're doing FFA. It's a routine
No, we are not
protocol
doing
you're doing?
We are not doing it. We don't have it here, the FFA RedCam. A study is going on in the Bhubaneswar campus of Prasada Institute, where Dr. Tapas is doing the study, just to understand our data profile versus the Western data profile. Profile from Dr. Paul Campbell and R.V. Paul Chen. They are the profound researchers in RO. Yes. So we are following up because they have unless they are from very far off, we ask them to go locally. But if they are from within 200, 300 kilometers, they also prefer coming to us because we follow them once in 6 months. Once the maturity happens is once in 6 months for the refraction, for strabismus. Sometimes these children can develop cataract, not because of the procedure. Okay, we had 2 cases where cataract happened because of the trauma, like because of the iatrogenic cataract. But some individuals do develop cataract. The reasons I do not know. But it is we hand over to the pediatric ophthalmologist to take care of it.
How is your experience with Eylea you mentioned?
Not used.
Achha. And not the brolucimab also? That is
brolucimab I'm never going to use with
Achha,
children.
because I just thought it was mentioned, so not
No.
used.
Yes.
Okay.
You can't risk it with the inflammation when the results are not known. No one is doing it.
Because aflibercept is recommended, but
good.
I'm not sure how many
See, the
people are
cost factor
injecting.
plays a big role here. Like they're already spending so much amount in the NICUs.
Yeah.
When they come to us, they have hardly any money left. So those factors also keep up. Like I think doctor explained about empathy towards the mother. Here it's a big role about empathy towards the family as well. So those things are not covered here. You can't cover in this. Yeah.
Another thing is, I think the longest duration of action is only of Avastin.
Yes.
That's what I was asking. So
Yeah.
even Avastin is your preferred choice still, or you
Yes.
do
Avastin is the
Yes,
preferred choice.
yes,
Again,
even
we have an advantage of an institute where we have a good micro backup and things. But outside, people, it's a risk because it's an individual choice, a doctor's preference.
But we have given Razumab and we have not seen any cases of recurrence that often.
That's very good. How much your sample size?
So it was 150.
That's really
so
good.
we have
You
not
should publish
seen,
it.
yeah,
And that
so
is the case.
not really many patients have had, and as per as myopia they were discussing. So we've said around moderate myopia, maybe around -3
Correct,
or -4. High myopia usually with lasers.
I think it's important that you can publish that Razumab data, right? If
Yes,
it-
Dr.
yes.
Mehul.
Yes.
We also use bevacizumab,
Correct.
and very rarely we need to re-inject the bevacizumab.
Exactly. Yes. So again, you are at an institute. You have an advantage of the entire team being there and all, right?
Okay.
Thank you so much.